Pelvic floor prolapse. So if you think of the pelvic floor as the base of the cylinder, the abdomen's other side and the diaphragm is the top. And prolapse is descent of the floor and the contents of the floor, which are your organs: bladder, bladder tube, vagina, uterus, anus, rectum. The contents fall down into the vagina. So pre-pregnancy, you can think of the vagina as a potential space. Post-babies, you think of the vagina as an actual space. So you think of it as an open column, and that these things fall forward and backwards and descend down into the vagina. It can extend past the opening, and then that is quite a severe prolapse. So 50% of women who've had babies will have prolapse surgery, and that means that their prolapse is severe. So it is a significant issue for women who've had babies. And it's significantly worse if you've had vaginal births and cesareans. So now, the thing with prolapse with regard to Pilates is increased abdominal pressure. So every time you think of an exercise that requires core work and that person is not able to maintain the supermodel belly flat, they have got increased abdominal pressure. And if their abdomen is moving out, then you can just about bet your bottom dollar, that's a pun, on the bottom coming out.
Okay.
So if it's expanding forwards, it's going to expand downwards, and it's to do with the diaphragm contraction and the psoas contraction trying to carry whatever the burden of the activity is that you are doing. So your job is to cue people into their transverse abdominis to keep it flattened in, but also to cue them on their pelvic floor. So you are cueing things like keep the inside edge of your sit bones together. So you think of the sit bones, this is not real, but you think of the sit bones as the outside perimeter of the vagina. You're trying to keep the sit bones together, you're trying to keep the vagina together. So the belly is a guide to what's happening underneath. Okay, so it's probably true of more than 95% of people you're going to see. Okay, so if their belly is popping, their pelvic floor is popping. So you are going to reduce load. So if a person's belly is popping, then you know you have to reduce load. So for instance, and the name of this is...
Single leg stretch?
Okay,
No.
so if single leg stretch was causing belly pop, then you would tell them single leg stretch up at 20 degrees rather than down at 85 degrees. So you also want to be aware of the element of fatigue. And this is a real issue in Pilates across the board. So if you've got someone doing something and you're looking at them doing something well, you tell them, I want you to check in with your body every 5 repetitions to make sure your belly is still flat and you feel like you still have vaginal floor elevation. Okay, so the other thing about prolapse is you've only got control over the muscles, you don't have control over the fascial descent. So you can only use the muscles up to a certain level. There will be a point where the fascial stretch, elongation, no amount of pelvic floor lifting is going to combat that.
Okay, perfect.
Right, so then it's give them a rest. Do
Yep.
tummy, do something else. Do tummy, do something else. Do tummy, do something else.
Would you
I'm
say
done.
as a teacher, coming back to that when people have pelvic floor prolapse, the tummy, working your abdominal muscles, like it is going to be the main focus of your classes? I mean, you're
Okay.
always working your abdominal muscles in Pilates, but...
Yeah. So you as a teacher are tuning into their tummy because it's what you can see.
Like as in you're
Yes.
cueing it?
Yes,
Yep.
but you want to get them the idea that pelvic floor and tummy are meant to work together.
Yep.
And so you have to cue them into, I can't see your pelvic floor, I can only see your tummy, so you have to tell me what you can feel. So usually, and you're going to educate them, so usually your tummy will fatigue at the same point as your pelvic floor, but that might not be the case. Your pelvic floor might fatigue before your tummy.
Perfect.
So if you don't feel like you have got that elevation, you need to stop what you are doing and rest. I teach inversion. So inversion doesn't cure the problem, it relieves the problem. So if someone has that prolapse sensation, I'm going to get them to do, it's called knee chest. So your bottom is directly above your knees and your head's down, and you're just hoping that the pelvic floor contents are falling uphill.
Mm-hmm.
And so you might add in contractions, which just help push it up. And then you just think of every other version of that. So you can have someone with, you know, I can't think of what it's called in yoga. This one.
Oh, like a candle kind of.
Yeah. Okay.
Oh, yeah.
And so,
Go, Annie.
Hi, my name is Matt, and I've been asked to have a chat to you today about stress fractures. So stress fractures can occur when there's repetitive submaximal loading of bone, resulting in microtrauma and ultimately in fracture to the bone. So there can be extrinsic risk factors to cause stress fractures. These can include excessive and abnormal training loads and hard surfaces. Intrinsic risk factors include health and diet factors, which may impact bone density and biomechanics as well. So exercises that you would recommend during stress fracture. Basically, initially there needs to be a complete period of rest for that bone. This could be up to 4 to 6 weeks. And in the case of metatarsal stress fractures, which I commonly deal with as a podiatrist, this may be in the form of a cam walker or a cast. Once the bone is healed, the patient will be progressed through a walk, jog, run, jump, hop program. So basically, whilst the patient's in a cam walker or cast, an exercise program for the rest of the body is obviously highly encouraged. So a lot of what you guys do in Pilates can be used during this time. Following coming out of the cam walker and the cast, it's important you ask the patient where they're at in that progression from walk, hop, so walk, run, jog, and jumping to see what they're capable of doing and tailor a program accordingly. If you have a patient that you come in complaining of pain that's yet to get a diagnosis, be very wary of pain that continues to increase with activity. So it gets worse the more it gets loaded. That's a really surefire sign often of bony injury or a pretty significant other injury. If they come in sore and it gradually warms up, but then they get a bit sore again after activity, that's more likely a soft tissue injury. In either case, it's probably best to send them to a health professional first and then get given some do's and don'ts for them so you can tailor a program for them around those requirements. Hope this has been of some help to you.
Hi, I'm just giving you a bit of information about fibromyalgia, and I do have a client that I teach on a Wednesday night who's had 19 years of pain. She generally has 7 to 10 flare-ups per year. My client is here once a week. She also sees other health practitioners, myotherapist and a chiropractor. And she finds she gets relief from the chiropractor, who does quite a lot of ultrasound work with her. Her pain is generally in her neck and down the right-hand side of her body. And I should have said at the very beginning that fibromyalgia is an autoimmune disease. And basically, I'm a sufferer of RA, rheumatoid arthritis, and I've been diagnosed with that, but Kate can't get a diagnosis, so she's not diagnosed with a particular autoimmune disease, so they generally say that she's got fibromyalgia, which is a massive generalization of someone in pain. So it's not very pleasant for her, but she manages it quite well. I'll pause to just let you know what she has to take in medication because I find that really interesting. Mm-hmm. So Kate takes 2 Panadol Osteo in the morning, a multivitamin and a product called Cramp Ease to help her with her pain. She also repeats the Panadol Osteo at night, so there's 2 in the morning and 2 at night. A Cramp Ease at night, and then another product that I'm not familiar with called Cymbalta. So you might like to research that and see what that is, but these give her relief. She works full time and she doesn't usually take much time off work, but obviously she needs pain relief.
All the time.
Yes.
Wow.
So it can be quite debilitating, but because she has it in her neck and down the side of her hip, it's less restricting than if she had it in lots of joints. So Kate enjoys things in the Pilates studio like lots of movement and mobility of her spine. We do a lot of things to start with that will release her low back. So we do cats and kittens, we do wall roll downs. She's quite capable and mobile in her spine. And she finds the spinnaker stretch amazingly relieving. So she loves that lateral flexion. But this is obviously just her particular body. General maintenance of obviously core strength and understanding where her hip is in space help her. So another exercise Kate really enjoys is legs in straps, either on the Reformer or the Cadillac. The Cadillac obviously being a little bit harder with the springs, but she loves legs in straps and circles.
And is there any like mat exercises apart from the roll down stuff?
Yeah, she's better, to be honest, she's better with supported studio Reformer or Cadillac or Wonder Chair work. I find she doesn't have the overall body strength to do mat work on her own, but she's a studio client, which I didn't mention at the start. She's not someone that I'd recommend to go straight into a mat class, although she's been doing Pilates for a while. And I do recommend that she moves a lot during her workday, and she's currently, I think, negotiating to get a stand-up desk.
Amazing.
Because with her hip, obviously hip flexion over a long period of time can be, a little bit annoying. Any hip flexor release is really awesome for her, particularly on that right side. And for me, I found that her inferior glute strength is a little bit waning, so we work on that quite substantially. And this is a girl who was so shy when she first came into Pilates, and now she talks to the whole studio and shares her story. So that's a little bit about my client with fibromyalgia.